The 2025 NEI Spring Congress attracts mental health practitioners from around the world to engage one-on-one with expert faculty and driven colleagues, like-minded colleagues. Join us to experience an unrivaled educational program full of practical takeaways, where you will learn the latest advances in psychopharmacology and explore cutting-edge research on treatment strategies, side effects, drug-drug interactions, and management. If you haven't done so yet, please register today to join us in person in Philadelphia, my beloved hometown, or online via simulcast May 8th through the 10th. You can use discount code NEIPOD25. That's NEIPOD25 to save $100 on your registration at nei.global/SP Congress 25P. That's nei.global/SP Congress 25P. Discount is good on new registrations only.
Welcome to the NEI Podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI Podcast with me, Dr. Andy Cutler. And today, we have a topic that I think is extremely clinically relevant, and we have an incredible person to discuss this with. My good friend and fellow NEI faculty member, Dr. Jeffrey Strawn. Jeff, how are you today?
I'm doing great. Thank you so much. I am really excited to talk about this.
All right. Well, let's just get going then. You know, benzodiazepines, we don't want to prescribe them, Jeff, but they're so darn effective that they are commonly used, yes?
It's so true, and they're incredibly commonly used. But another problem with benzodiazepines, ironically, is that in many situations where they can be truly helpful, for whatever reason, as clinicians, perhaps because of our own guilt about using benzodiazepines, we don't. And so we're really in a difficult spot, Andy, where we need to balance unnecessary prescribing with judicious prescribing of benzodiazepines when and where they actually can be helpful. We can't forget the fact that this class of medications, one of the first approved for the treatment of anxiety disorders, is tremendously effective and can produce fairly rapid improvement in symptoms.
Yeah, that's so well said. I think you're summarizing the pros and the cons here, which are really large on both sides, but I think exaggerated or underappreciated as well on both sides. I think some people are irrationally afraid of benzos or have stigmatized them on the one hand. And on the other hand, I think some people have gotten a little bit comfortable or maybe desensitized to some of the risks. So what would be some of the risks in either short or long-term use?
So that's a really, really good question. And like with any class of medications, I think that we always need to consider the risks. Now, with regard to the benzodiazepines, we know that these are a class of medications that can impair memory, both explicit and implicit memory. They certainly may increase the risk of motor vehicle accidents. They are associated with tolerance, and particularly when they're discontinued from high doses, withdrawal symptoms. Now, there are some other side effects or risks that we often hear about, which really are somewhat not supported by the actual literature and by meta-analyses. So I'm sure you've heard that benzodiazepines increase the risk of dementia or major neurocognitive disorder, right?
I have heard that, but I never fully believed it. So I hope you're going to help me with that.
So get this, Andy. There is actually a dose-dependent decrease in the risk of neurocognitive symptoms with benzodiazepines. Now, do I think benzodiazepines are actually treating major neurocognitive disorder or having a protective effect? No, I do not. But one of the things that we know is that anxiety is actually a significant risk factor for major neurocognitive disorder and mild cognitive impairment. And so what I think is actually happening here in terms of that quote unquote protective effect is that we're actually seeing the benefit of treating the anxiety with an effective, efficacious agent. Now, the other side effect, which is often reported in the literature, although variably supported by meta-analyses, is the risk of fracture. So what do we know about that? It's been evaluated in pediatric samples as well as in adults and in older adults. And one of the things that we know is that risk seems to be small, but interestingly, it seems to be acute. So the highest probability of experiencing a fracture occurs within the 1 to 2 months after initiating benzodiazepine treatment. Now, as I talk about this conflicting literature, I'm not meaning to give our listeners a false sense of security. These are medications, and like any other medications, do have risks. And those risks should always be evaluated in the context of their potential benefits.
Could I drill down a bit on both of the two kind of myths that you just talked about? I'm going to start with the fracture. Is that related at all, Jeff, to the risk of falls, which we know is a very real risk because of the impairment of coordination?
Certainly, it's probably confounded by falls. One of the things that we notice when we look at many of these studies is that it's certainly more likely for someone to detect a fracture following a fall, whereas some of these more incipient fractures or smaller fractures may not be detected. So this is one of those situations where, unfortunately, like in many psychiatric studies, we have tremendous amounts of noise that probably obscure our ability to really detect some of these signals.
Yeah, that's well said. And you and I are both researchers, and we're always trying to control for confounding variables and things like that. So yeah, I know exactly what you mean. I want to get back to that first thing you talked about, which is very controversial, this issue of the risk of dementia, cognitive impairment. I'm really struck by something you said, which kind of relates to the whole way we're conceptualizing mental illness now, even more broadly than just anxiety. And that is the idea that stress is neurodegenerative or is toxic to the brain. And I'm thinking about this idea of successfully treating anxiety, of course, is going to decrease stress hormones, cortisol, and so on, and certainly may be better for the brain. We know that mood episodes, psychosis, mania, any of these things are toxic to the brain. And so that's just a fascinating kind of association I'm having here.
Absolutely. I think maybe just to riff on that a bit more, when we think about anxiety disorders in particular, and we think about overlapping symptoms with many of the neurocognitive disorders, we know that individuals with an anxiety disorder will have reduced processing speed, will have reduced working memory. Well, if I have reduced processing speed and working memory, depending on where I'm starting out, my baseline, that may look very similar to cognitive impairment associated with a neurocognitive or neurodegenerative process.
Well, Jeff, I think our audience is very familiar with the issue of cognitive impairment in psychotic disorders, in mood disorders, depression, and mania. I don't know that people fully appreciate the cognitive impairment associated with anxiety, frankly.
I think this is something that we've underappreciated as a field. And get this, Andy, this is not just in adults or older adults. These findings have actually been demonstrated in pediatric samples as well.
Absolutely believe it. I mean, we can all think from our own personal lives, if you're very stressed or anxious, how clearly are you thinking and how well are you paying attention, for instance? And certainly in the differential diagnosis of a kid who's brought to me who's inattentive, it would be anxiety or an anxiety disorder.
Absolutely.
Okay. Well, let's move on because obviously our topic today is benzodiazepines, and especially when you get to the point when you're ready to stop them, how to taper. And I love the term, Jeff, deprescribing. And this also relates to something that another one of our colleagues, good friend of mine, Jonathan Meyer, and actually Les Citrome and I have been talking about, which is deprescribing anticholinergic medications, which hopefully we'll do a separate podcast on. But I know you agree that that's a very important topic.
Absolutely. But I think this is something that's gained some traction within the psychiatric community. It's fascinating to me, Andy, that when we're thinking about deprescribing as a field, it's as if this is something new. We never actually think about stopping medicine when we're starting many of these medications or adding an augmenting agent or cross-titrating. I think there's this hesitancy in the field sometimes to deprescribe. And we have an upcoming book on deprescribing in psychiatry. And I found myself as a clinician thinking more and more about deprescribing as we've been working on this book, which I think for me is a very interesting phenomenon.
Yeah. And that's a book you're writing with Dr. Stahl, I believe?
That's correct.
Oh, boy. That's wonderful. You're going to appreciate this joke, Jeff, which I started telling when you were probably back in, I'll say junior high school, something like that. But that is, and I'll tell you where I learned it in a second. But the joke is, I think I've done more good in my life taking people off medicine than I have putting them on medicine. And where I came up with that was I was doing a lot of work in nursing homes. I was doing some of those trials with atypical antipsychotics back in the early 2000s in nursing homes and dementia. And I saw these people on these crazy combinations of medications, and I started trying to clean them up a little bit. But this is something we're not well trained in. I certainly can speak from personal experience. I'm not sure, Jeff, more modern training. I don't think we're trained very well in this idea of deprescribing. And I think, as you said, sometimes when somebody gets put on a medicine, other clinicians are hesitant to want to take them off it, and people accumulate medicines over time.
Absolutely. To go back to your point, I agree with you that we're not well trained in terms of how to deprescribe, but I wouldn't necessarily fault our educators because I think they're at a disadvantage as well because we don't have the evidence for how to discontinue, the rate of discontinuation, when to discontinue, how to, for example, cross-titrate from one medication to another. And this is something that's really become apparent as we've exhaustively been researching how to stop many of these medications that we use so commonly.
Unfortunately, this is one of those clinical situations where we're just kind of practicing more on our judgment than on an evidence base. And I agree with you that there's very little evidence. Certainly in the kinds of studies I've done over my career, the industry-sponsored clinical trials largely geared to get a medication FDA approved, there are very few such studies with our newer medications on that. And I guess also because when we're talking about benzodiazepines or anticholinergics, these are medicines that have been around a very, very long time. So usually the impetus to do some of those studies is more early on in a drug's life cycle, I would think.
Absolutely. Absolutely.
Well, let's move on with our discussion here. We talked about some of the risks and some of the long-term risks. And I think we're all familiar with using a benzodiazepine for a more acute or short-term use. But as we talked about, many benzodiazepines are used chronically. And I want to also mention what you said earlier, which is these were the first drugs FDA approved for anxiety disorders. And a mentor and good friend of mine is Dr. David Sheehan, who did some of the first work and was really involved with getting these approved. He was really an expert in anxiety disorders at the time. But what happens now when someone does take these medications for the long term? Are there neuroadaptations that occur? I know there's physiologic adaptation.
There certainly are adaptations that happen in a patient who's chronically treated with benzodiazepines. Now, one thing I probably need to emphasize here is that there's often a bit of extrapolation that comes from preclinical studies, because in many of these situations, we can't directly assess what's happening at a receptor pharmacologic level in humans. That being said, there are a couple things that we do know. In patients who are chronically treated with benzodiazepines, we know that there is a desensitization of the GABA-A receptor. We also know that there are changes with regard to glutamatergic sensitivity. So there's upregulation of some of those glutamatergic receptors as well. We also know that long-term treatment with a benzodiazepine will actually decrease transcription of the GABA-A receptor. And one of the things that I think is really important here is that when we stop the benzodiazepine, particularly if we do so abruptly, we're now in a situation where we have changed the gain on that system or changed the sensitivity. And we think that this is probably one of those things that subtends many of the withdrawal symptoms that we may see, particularly with regard to agitation and rebound anxiety. But there's more than just what's happening at a GABA level. And one of the things that we increasingly appreciate, particularly over the last year as we think about things like xanomeline trospium, is that GABA has significant roles in terms of regulation of dopaminergic tone. And so one of the things that we also know is that acutely, benzodiazepines shift the tonic control of VTA neurons. And so how does that actually relate to withdrawal? Well, one of the things that we then know is that when we withdraw that benzodiazepine, we actually can see decreases in dopamine release from the nucleus accumbens, which may potentially look like amotivation or disinterest or perhaps even neurocognitive symptoms. So many cases, the chronic effects of benzodiazepines are really more than just at GABAergic neurons. They affect other monoamines like dopamine, norepinephrine, and even serotonin.
Of course. Well, I always say, these things are so interconnected. And what we're really talking about is this balance. And sometimes I refer to a term I've learned more recently, which is allostasis, not homeostasis. But when you do a type of intervention, the brain seeks a new level of stability, if you will, or equilibrium.
I think you raised a really important point, Andy, which is that this is not homeostasis. This is allostasis, a different phenomenon here.
Mm-hmm, mm-hmm. Yeah, and you've also helped me understand something else, and that's the risk of seizure. Obviously, if you're down-regulating GABA, which is protective against seizures, and you're upregulating glutamate, or certainly you're affecting that balance, that's going to make the brain more vulnerable to seizures. So that helps me understand that risk as well.
Absolutely.
Okay. All right. So now I'm putting myself in our audience's shoes, and I'm thinking, all right, how do I know when it's time to even to do this? How do I know when it's time to begin trying to get somebody off of a medication? In other words, when is the benefit not outweighing the risk?
That's a great question. And I think really, as I conceptualize when a benzodiazepine may be stopped, there are a couple scenarios. So first of all, when there's evidence of dependence or abuse, that's probably a situation in which we should really rethink whether the benzodiazepine's benefits are truly outweighing its risks. The second scenario, and this is in line with evidence and some guidance from the FDA, is when opioids are prescribed or needed concurrently. We know that that combination is associated with an increased risk of sedation, respiratory depression, and importantly, overdose. So this is a situation where I would really think about whether that benzodiazepine is still needed. The third situation for me is when there is evidence of cognitive impairment or falls. Now, we did talk a little bit about that earlier, but I think this is a situation where, again, I'm not necessarily worried about the benzodiazepine causing dementia, but I want to try to clean things up so that I've removed any potential contributor or confound to what may be happening neurocognitively. The next situation, and I've really run into this in several patients, particularly some of those with ongoing personality disorder symptoms, or even some patients with bipolar disorder, is when there's significant impulsivity. One of the things that we know is that benzodiazepines improve anxiety, and anxiety is sometimes helpful in terms of checking our behaviors or perhaps stopping us from doing certain things which we otherwise might not do. So for me, when I have a patient who has significant impulsivity, or perhaps impulsivity that I didn't initially appreciate, this is a situation where I am really thinking through whether benzodiazepine is the most appropriate treatment. And I think this is one of the things that may have particular implications with regard to suicidality. The next situation that I do think about is when I have a co-occurring non-psychiatric disorder. So I'm thinking about comorbid chronic medical conditions. So these would be things like COPD, etc. The next situation is when a patient's pregnant or considering becoming pregnant or breastfeeding. And in general, we try to avoid many medications in pregnancy. But certainly with regard to benzodiazepines, we have a lot of data, and that data does suggest that there may be significant harm, particularly even during the breastfeeding and early neonatal course.
That's very important, Jeff, because I don't know that everybody knows that. So thanks for bringing that up.
Certainly. The last two scenarios are really probably more judgment calls. But the first of those last two is remembering that we have limited data for long-term efficacy. Now, that's not to say that these medications don't have sustained effects in the long term, but when we're really looking at most of the randomized controlled trials, they're somewhat short. Now, part of that is because ethically, we can't continue patients on placebo for 12 or 16 or 24 weeks, but also in some of those longer-term studies, we get more dropout as the study continues. And so what you're left with is more of the placebo responders. And as a consequence, it looks like many of these medications in the long term are actually less effective if you're just looking at placebo drug differences. Now, the last scenario is at every visit, I really do try to think about, is this benzodiazepine still necessary? Why did I initially start the benzodiazepine? Is that indication still present? And is there still a favorable balance with regard to risks and benefits? And I think this is something for our listeners that may be helpful to even think about documenting in each of those progress notes.
Yeah, I could not agree more, especially with all of the scrutiny around benzodiazepines and around controlled substances. I think that's wise. But Jeff, you just said something very interesting that made me think, we certainly know that effective treatments for anxiety disorders include various forms of psychotherapy, such as CBT. There are even now some prescription digital therapeutics, some digital treatments that may be effective. So I'm wondering if use of a benzodiazepine in the acute setting or for a period of time while you're introducing maybe some of these other modalities, perhaps you may be able to now take the benzodiazepine away, so to speak, because you've used these other modalities.
I think absolutely you're raising a really important point, Andy. And if I can maybe just go on a brief tangent, if you'll allow me. One of the studies that was done at the VA by a very reputable group a number of years ago now was probably something that's been used to say that we should not use benzodiazepines in many of these situations where we do know that they may be helpful. Now, the study did look at post-traumatic stress disorder, which, again, we're thinking about anxiety disorders, not PTSD. But the study basically looked at individuals who were prescribed a high-potency benzodiazepine immediately prior to an exposure-based therapy. Now, the conclusion from the study was that benzodiazepines are unhelpful. Well, I think really this is where we need to be cautious in our interpretation. I would certainly not recommend administration of a high-potency benzodiazepine immediately prior to exposure-based psychotherapy. But benzodiazepines may still have a role. Again, I think this is often the nuance when we're thinking about these medications that unfortunately we miss.
Okay. Well, I can imagine now we've opened some people's eyes or got some people to think about situations where I now want to taper or discontinue. But I think many clinicians may be a little bit afraid to have that discussion. Maybe they're afraid the patient will get angry with them or so on. So what would you recommend for how clinicians can discuss this idea of discontinuing the medication?
So one thing that I would actually really encourage folks to incorporate into those conversations is that this is not just about benzodiazepines. And so what I often say with patients is that when we're at a place where things are better, we've generally achieved remission or response or other things are going better in the patient's life, is that I tend to like to look at all of our medications at every visit and determine whether this is something that's still helpful, or what is this medication potentially doing? What is its role in terms of the bigger treatment picture? The other thing that I will also talk about in very realistic terms is what are the ongoing risks relative to the benefits, and hopefully getting the patient's assessment of that as well. But I think the other piece that's particularly important as we think about patients with anxiety disorders is that there are cognitive aspects of anxiety disorders which may, if you will, perpetuate difficulty coming off of medications, including benzodiazepines. And this is where I like to think in terms of some advice given to me by my good friend, Dr. Catherine Dalsgaard, also on the NEI faculty. And Catherine talks about 3 big lies of anxiety. The first is over-predicting a negative outcome. So thinking about this in terms of dogs, the dog will bite me. The second is over-predicting a catastrophic consequence. So the dog will bite me and it will bite me in the neck. The third is under-predicting our coping ability. So if the dog bites me, there is nothing that anyone will be able to do to help me. And if we think about benzodiazepines, oftentimes these are medications that were started early in the course of an illness, perhaps when a patient was in much higher distress than they are currently. And so many of these same cognitive aspects are at play when we're thinking about patients' trepidation around stopping a benzodiazepine. For example, lie number 1, if I stop this benzodiazepine, something bad will happen. Lie number 2, I may completely decompensate. I could potentially lose my job. I could be demoted. Lie number 3, if I do have withdrawal symptoms or rebound anxiety, there will be nothing that I can do to stop that.
Right. No, that's a really excellent point. I hadn't thought about those kind of cognitive things. And especially, you mentioned something earlier, that these drugs work rapidly as opposed to, say, an SSRI. And so maybe it's become a little bit of part of their coping mechanism or a crutch, if you will. Okay, very helpful. So now, why is it that we're talking about gradual tapering when we talk about deprescribing as opposed to stopping more quickly?
So certainly, as all of our listeners know, abrupt discontinuation, particularly from high doses, can precipitate withdrawal symptoms, including seizures, as you mentioned, but also rebound anxiety and insomnia, as well as a number of neurocognitive and neuromotor symptoms. And so when we think about gradually discontinuing a benzodiazepine, this is a way that allows the brain, as well as the psychology of the system and the whole patient, if you will, to adjust to a slower change. At a receptor level, it also mitigates potentially some of those receptor pharmacology changes that we talked about earlier with regard to GABA and glutamate, and also with regard to dopaminergic changes.
Yeah, I sometimes like to say the brain doesn't like you to do things too fast. So this is a good example, certainly a good example of that.
People don't like you to do things too fast either.
That's true too. Okay, before we get into the nuts and bolts of how to do this, let's educate people a little bit about the difference between withdrawal from the benzodiazepine and rebound anxiety. So what are the withdrawal symptoms? What do they look like?
Andy, this is such an important point. It's so important. I'm going to actually rephrase and restate your question, which is, how do we differentiate withdrawal symptoms from relapse, really, is what we're talking about.
And I assume there's some overlap, Jeff, but you'll help us.
There is certainly overlap. And benzodiazepines are not unique in this regard. We could be having the same discussion around SSRIs or second-generation antipsychotics or many other classes of medication. So one of the things that I tend to encourage folks to look for is, what are those symptoms that may be more specific for benzodiazepine withdrawal versus just return of the underlying anxiety disorder? And so when we're thinking about those symptoms that may be more specific to benzodiazepine withdrawal, I think about a couple. One, I think about perceptual disturbances. I also think about hallucinations or formication, particularly in situations of acute withdrawal. We may think about sensory hypersensitivity. We may think about changes in muscle tone, muscle twitching, fasciculations, tinnitus, confusion, agitation. Now, as you alluded to, there's considerable overlap with regard to anxiety symptoms. So we may be seeing anxiety or panic attacks, either in terms of more frequent or more severe. We may be seeing that agitation or restlessness. We may be seeing many of the physiologic symptoms that initially accompany the anxiety, like dizziness, lightheadedness, palpitations, muscle pain, and stiffness. Now we're really getting into some overlap. And also, interestingly, sweating for a fair number of patients as they are stopping or tapering the benzodiazepines.
I was going to mention that, Jeff, because I've seen that quite a bit.
Absolutely.
Yeah, exactly.
And one pearl that I try to give folks is that when I'm asking about stopping medications and those symptoms that may be withdrawal related, is I will sometimes try to ask about what happens when they may miss a dose of the medication, so that we're able to assess how similar those symptoms are that they're currently experiencing to withdrawal versus symptoms related to recrudescence of their underlying anxiety.
Yeah, also, I think a careful inventory of their original anxiety symptoms, the original symptoms associated with their anxiety, because they are particular. There's different fingerprints, right?
Absolutely. Absolutely.
So then you'll have a better handle on that. You know, it's also occurring to me, Jeff, that if we withdraw too fast, what we're actually doing is we're really activating the sympathetic nervous system. We're talking about here a lot of sympathetic overdrive kind of symptoms.
We really are. You're absolutely correct.
Mm-hmm. All right. So this is extremely helpful to help clinicians. And you may not, it sounds to me like you may not be able to fully differentiate because of this overlap. And so in either case, of course, you'd want to slow down what you're doing or be careful with what you're doing. But in general, do you have some best practices for how to do this?
I do. And let me put a finer point maybe on what you just said. We have a really important diagnostic tool, and that is time. So this is a situation where we may take another couple days, or I may ask the patient to send me a message in the electronic health record or my chart or something similar to let me know how those symptoms, which maybe they saw in the office with me and we discussed on Tuesday, are doing by Friday, so that we can get a better picture of the stability or perhaps the improvement associated with those symptoms.
Mm-hmm. Yeah, and I think it's obviously going to be very important to personalize the schedule. I don't think there's a cookbook way to do this tapering and deprescribing.
You're absolutely correct. And this is one of those situations where we need to not probably treat all benzodiazepines the same. I think oftentimes when we read our practice parameters or our treatment guidelines in psychiatry, they're somewhat one size fits all, which is something that I find immensely frustrating. It's as if all SSRIs or all benzodiazepines are equivalent to one another. And we know that they are not only in terms of efficacy, but also in terms of the ease with which they can be discontinued. And so to really delve into how I would stop benzodiazepines, the first thing for me is knowing that I've optimized psychopharmacologic as well as psychotherapeutic treatments. And ideally, I've gotten that patient to the remission threshold. That's important because we know that there are a couple of clinical factors and pharmacologic factors that may predict how difficult it is for someone to stop a benzodiazepine. So marching through those, we know that panic disorder or higher pre-treatment anxiety or depression, as well as personality psychopathology or concomitant substance use, are among the most important clinical factors that portend more difficulty stopping a benzodiazepine. Now, on the pharmacologic side, we know that higher doses, shorter half-life benzodiazepines, more on that in a second, and longer duration of therapy, as well as more rapid taper, also predict more difficulty stopping a benzodiazepine. Now, in psychiatry, we often get really obsessed, if you will, around half-life and short half-life versus long half-life. But with the benzodiazepines, one of the things that I think is really important is that it's not just half-life that determines many of these differences in terms of one benzodiazepine versus another. There's the issue of lipophilicity. And in many cases, that's going to be a primary driver of duration of action, because these benzodiazepines in general tend to vary in terms of how lipophilic they are. And so when you take a benzodiazepine that has high lipophilicity, it tends to have a somewhat more rapid onset. Why? Because it gets into the brain, which is largely fat, more quickly. But the other piece is that it also leaves the fat more quickly. And so we get more redistribution of that benzodiazepine. And that dance, if you will, in terms of that lipophilicity-driven dance, is one of the most important factors in terms of duration of effect, which is also important with regard to discontinuation. That was a lot, Andy. I'm sorry for that.
No, very helpful. And what occurs to me is, of course, the classic example of high lipophilicity is one of the older ones, diazepam or Valium.
That's the example.
It's the one I think of, yeah. All right. Well, Jeff, that was actually an excellent summary of those kinds of factors we need to consider for each patient and each of the medications. So how do we now put this into practice? How do we now actually do this?
I thought you'd never ask. With regard to stopping benzodiazepines, in general, when we look at the guidance, it suggests decreases of about 10% per week. Now, do I always decrease by 10% per week? I do not. There are certainly situations, particularly if I have a patient who's decreasing from a very high dose or who's had chronic treatment, where I may decrease the dose more slowly, or I may decrease by 10% every other week or even every month, depending. Now, I should probably also say that this is in a general outpatient setting. Certainly in a highly monitored inpatient setting where we need to discontinue more rapidly, we certainly can do so. But this is for more of a stable outpatient in whom I'm truly deprescribing. Now, if the response is maintained, then I generally continue that taper. However, if I start to have either withdrawal symptoms or perhaps even recrudescence of the anxiety, I may then begin decreasing the dose by every other week or even monthly, as I alluded to earlier. Now, there's one very, very special scenario, and I'm sure all of our listeners already know what I'm about to say. And that is the situation where we have a patient who's treated with high-dose alprazolam. I have generally not been successful in terms of decreasing directly from alprazolam in an outpatient setting. So what I generally do, if I have a patient who needs deprescribing of alprazolam, what I will generally do is convert to a longer acting benzodiazepine at about 100 to 125% of the equivalent dose. And there are wonderful tables that you can use in terms of the equivalence in terms of dosing among these different benzodiazepines. Now, after I have restabilized the previously alprazolam treated patient on another benzodiazepine, I will start tapering as I described earlier. Now, in some situations, even those slower discontinuations, 10% every other week or 10% every month, can still cause or be associated with some withdrawal symptoms. And this is a situation where I really think about adjunctive interventions. And there are a couple that have actually been studied either in open label trials or in very small case control studies as well. And these are things like buspirone, trazodone, pregabalin, which is approved in the European Union for generalized anxiety disorder, but not in the US, as well as divalproex. And certainly I'll consider other things depending on very specific reported symptoms. So for example, if I'm running into issues with initial insomnia, I might think about something like azopiclone or zolpidem or even one of the orexin modulators.
Mm-hmm. What about alpha-2 agonists such as clonidine?
I probably tend to use more of the alpha-2s in the pediatric population, where we generally use them much more commonly for insomnia.
The reason I asked, Jeff, is I know that they are evidence-based, proven to help with opioid withdrawal. And again, we talked about this sympathetic overdrive.
Yeah, so Andy, I can see exactly where you're going with the sympathetic overdrive with regard to the alpha-2s. I tend to use them a little bit less commonly, as I mentioned, in adult patients, and I'm not aware of much evidence with regard to the alpha-2s in benzodiazepine withdrawal. However, there have been some interesting reports looking at propranolol and other beta blockers for mitigating withdrawal symptoms.
Okay, so that makes sense, certainly. Okay, so that's really helpful, too, that there are other adjunctive medications that can be used to help support this process. And I love what you said about, even though the classic recommendation is 10% per week, weekly tapering may be too rapid for many patients, particularly those on higher potency or longer duration. But what about the elderly?
This is a situation where, again, barring any acute indication for stopping the benzodiazepine more rapidly, I tend to go even slower. Now, one of the things that I do tend to observe, at least in my practice, is that the older adults that I tend to see are generally treated with lower doses of benzodiazepines, and actually, in fact, different benzodiazepines than many of my younger patients, meaning middle-aged patients.
Mm-hmm. What do you mean by that? What kinds of differences in the benzodiazepines?
So we see a little bit more temazepam. We see a lot more lorazepam in older patients, at least in the region where I practice, versus a lot more clonazepam in more of the middle-aged and younger patients. And I think some of that probably reflects the time at which these benzodiazepines were initiated.
Mm-hmm. Yeah, alprazolam's another one that gets used a lot, of course. Famous Xanax.
Absolutely, absolutely.
Yeah, lorazepam's interesting because it has a different metabolism from many of the others. It tends to have less liver metabolism, and certainly that was the one that we used a lot when we were withdrawing people from alcohol because of the concerns around the liver.
Certainly that old mnemonic that we all learn a lot, the lorazepam, oxazepam, and temazepam, referring to the benzodiazepines that are not oxidatively metabolized.
Exactly. All right, well, this has been extremely helpful, and we did touch on something, but there's something else I want to talk about, and that is you talked about some of the negative cognitive biases around anxiety, and we talked a little bit about CBT, but can CBT be effective specifically to support the tapering of the benzodiazepines?
I think CBT can absolutely be helpful in terms of supporting deprescribing of benzodiazepines. And you gave me a great opportunity to talk about one of my favorite studies, which is a study that actually looked at the cognitive factors that influence how easily a patient can discontinue a benzodiazepine and how likely that patient is to relapse after stopping a benzodiazepine. And as we talk through many of the findings of the study, our listeners will probably appreciate the way in which these are distortions and cognitions that are very amenable to CBT. So a couple things that we know are that the patient having more worry or anxiety about discontinuing the medication is a significant risk factor. But there are a couple of factors that drive that anxiety. One is side effects. The second is a feeling of safety or security with the medication. And the third is less coping confidence or feeling less confidence in your ability to cope. So again, going back to line number 3 from Dr. Dalsgaard. Now, the amalgam of those cognitions is, again, the most important driver of that anxiety about discontinuing the medication. Now, here's where it gets really interesting. The anxiolytic effect of the drug in itself is something that tends to undermine the patient's ability to credit themselves with improvement. So if the drug was more effective, the patient will discount their beliefs that they had any role in the recovery. Now, the other thing that is certainly important with regard to the taper phase is if folks are having worsening anxiety or increasing agoraphobia and avoidance, those are independent predictors of relapse and difficulty discontinuing the benzodiazepine. And again, I think these are things that are very amenable to work in psychotherapy or even booster work in psychotherapy if the patient has already completed a course of CBT.
Again, very, very helpful. Along the lines now of, we talked a little bit about how to have that conversation to introduce this concept or this topic or the need to do this. And what you were really describing there, of course, was shared decision-making and getting the patient to buy into this. But what other information should be provided to the patient before you get going on the taper?
Man, Andy, that is another really good question. I can see why you host this podcast. In terms of thinking about that discussion, we've already talked a little bit about a summary of the risks and benefits and also normalizing the process in that this is not something specific to benzodiazepines, but this is something that we should do for every medication, really at every visit. Now, thinking about the fact that we're often using the benzodiazepines in anxiety disorders, I think there are a couple other cognitive considerations here. One is that a huge driver for many of my patients' anxiety is uncertainty. And so the more information that I can potentially give to the patient as we're even contemplating a withdrawal is what might happen. But not only what might happen, if that does happen, is it likely to be time limited? Is it likely to resolve spontaneously? Is there something that we can do collaboratively to manage a withdrawal symptom? Also, them knowing the fact that this is a dynamic process. This is not something that we will start and essentially set on autopilot. This is something that we generally have the flexibility to slow down or to even pause if we need to. So I think that reassurance around what the course may look like is really critical, particularly when we're thinking about anxiety disorders.
Boy, Jeff, you've said that really well. I think uncertainty 100%, but also the sense of not being in control. And so if you talk about it as a collaborative process, that I will have some control in this process. You know, once we start this is not an inevitable way we're going to do it, that we can adjust and adapt based on what I'm experiencing or what's happening. I think that's extremely important to give them. I always like to say patients don't like surprises, you know, so you want to always
Neither do clinicians.
Well said. I hadn't thought of that aspect of it as well. You're right.
Or at least this clinician.
Yeah, no, I don't think you're unique in that regard, Jeff. You're unique in some regards, but not necessarily in that regard. Okay, so we're getting towards the end of the time here, and I want to think about maybe another kind of way of conceptualizing this for our audience. How can clinicians balance the patient's preference with the evidence base here and with what maybe we feel like is really what needs to be done or what's in the patient's best interest?
So coming back to what we just talked about, and I love your term, because balancing patient preferences really involves this idea of shared decision-making. So we know that evidence-based practice should guide the process, but it's really critical that we respect patients' concerns, such as their fear of withdrawal or fear of losing symptom control. And we have to tailor the plan both psychologically and pharmacologically to accommodate their preferences while ensuring safety. And I think ultimately that's the way in which we can enhance adherence to this whole deprescribing process. I think one of the other things that I will sometimes do in that regard is that as we are maybe in some patients using PRN benzodiazepines, I'll encourage them to start tracking when and where they're using that benzodiazepine. And we'll actually look at that over the course of the taper. And so we may, for example, set a goal that we're going to decrease the use of a PRN from 4 times a week to 3 times a week. or that we're going to perhaps wait until anxiety is at a certain threshold, again, so that we can learn to tolerate the distress that may come with some of that anxiety. I think that's something that can really be helpful, particularly when we're thinking about PRN regimens, which is something that we haven't really talked about.
Yeah, well, that's certainly true. I love that idea of keeping the diary, if you will. I think that's very helpful when we're treating many different disorders, because sometimes it's hard for the patient to remember from the last visit to now. You're sort of asking them to remember and report. Whereas if you really can get the data in the moment, and I like the idea of what you said, it's not only when I take it, but what situation am I in, or what am I feeling at the time? And I guess what you're also talking about here is a little bit of mini exposure therapy when you talk about trying to delay when I take it to be able to tolerate a little bit more anxiety and show that I can handle it.
Right. That ability to tolerate distress is something that is so important across many conditions, but particularly anxiety disorders. And oftentimes patients will really, again, going back to line number 3, underestimate their ability to tolerate distress. And this is one of the questions that sometimes I'm asked as we think about deprescribing. What if I become anxious? Well, you may become anxious, but here's the plan for if you do become anxious. And we'll talk about allowing that anxiety to build to a certain tolerable threshold. Again, we don't want it to get to a 10 out of 10, but we actually may want it to get to a 3 or a 4 out of 10. Because that's ultimately what's going to facilitate the patient learning to tolerate more of that distress.
Yeah, I think also helping the patient to be proactive. In other words, let's not wait till this happens, but let's think and plan out what other options do I have? What else can I do to manage the anxiety besides just grab a pill? And we certainly know this from the substance abuse literature that what tends to happen with people with substance abuse is they develop very limited options. And so they hurt, they use, that kind of thing. And so helping them to break that cycle. Yeah. Well, you have alluded to a very important resource that is coming, I guess. You're writing a book with Dr. Stahl. So I'm sure by now our audience is wondering, where and when is this book going to appear? I want to get a copy. So what can you tell us?
So they're going to have to wait about a year for the book to come out. But I promise that we will begin sprinkling some of this deprescribing wisdom into our talks at NEI and perhaps maybe even into other podcasts and other places on the NEI global platform.
Well, that would certainly be wonderful. So just to remind people, in case you're listening to this at a different time, we are recording this in early 2025. So I guess our goal would be early 2026. And Jeff, you're piggybacking right on to what I usually talk about at the end of every podcast, and that is, what are these NEI resources? Well, first of all, everybody may be aware we have 2 live meetings a year. We have rebranded the naming. We used to have what we called NEI Congress in the fall and then a Synapse meeting in the spring. We're now rebranding them as the NEI Spring Congress and the NEI Fall Congress. Fall Congress every year is in the lovely Colorado Springs at the Broadmoor Resort. And in the spring, we move it around. This year, it's going to be coming up in Philadelphia, my beloved hometown of Philadelphia. We also do a virtual CME meeting. We call them, unfortunately, it's not the most original name, but Saturday Morning Lives. Not surprisingly, on a Saturday morning, a half day where you can get CME credit, also hear an industry-supported a promotional talk, as well as something that's really unique, which is what we call a poster session that I moderate, where we have someone presenting newer data as if it were a poster to the audience, and of course have Q&A. But if you want to find out, and always, as always, podcasts, which you can find on any of your podcast platforms, but if you want to find out more information and even get more products and services, please just go to our website, which is neiglobal.com. And so on behalf of NEI, I want to thank you for listening. I hope you found this to be helpful. And I especially want to thank you, Jeff, for taking some time and sharing with us your considerable expertise and wisdom.
Oh, my pleasure. These are always the highlight of my week, listening to the NEI podcast. So it's even a greater highlight being on one of the NEI podcasts.
Oh, that's great. I'm surprised, Jeff, as I go around the country, how many people stop me and tell me, I listen to your podcast. So I think we are hopefully having some reach and doing some good. Well, thank you again for listening, and please check out our other podcasts on a variety of topics. Take care.
Thanks.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.